Hello everyone, this is Miss Gerald, and I'm going to be covering the concept of assessment. I wanted to record this PowerPoint to make sure that you had some key information that I wanted to point out before class on Tuesday, August the 18th. So please take notes. I don't expect for you to listen to this PowerPoint at one setting. It will be rather lengthy, probably about an hour, because assessment is so key to nursing. It's important that you know how to complete an accurate and thorough assessment from both taking the health history and performing the head-to-toe assessment. So it is lengthy. I suggest that you take maybe about 20 minutes at the time, listen, take notes, go back, listen again. You will have the opportunity to listen to this PowerPoint throughout the entire semester, okay? So it will be available for you for your test and for the final exam. Okay, so the concept of assessment. Here are your objectives. These objectives come directly from the course modules that you will find on the LMS. I know you don't have access yet, but you will have access the first day of class. So here are your course objectives. I am not going to read these for you. They are there. They are very self-explanatory, but I always tell students, you need to know how to answer your objectives. Look at your learning objectives as though they were questions. So if you can understand how to answer all of these questions, or look at these objectives as questions, then you really have gained a general understanding of the concept, okay? Your learning objectives. All right, here we go. The purpose of assessment. Your book states health assessment is a systematic method of collecting data about a patient. So when you collect this data, you do it in two parts. You have the health history interview, and then you have the physical examination, which is your head-to-toe assessment. So health assessment is it's a systematic way of collecting patient data or information, findings, another name you will hear me say. Instead of data, I will say findings or patient information about the patient. It includes health history interview and the head-to-toe physical examination. So why is health assessment important? Your book has 4 different reasons why health assessment is important. And like I said before I even started into this PowerPoint, knowing how to complete an accurate and thorough assessment from taking the health history interview to the head-to-toe examination is crucial for nurses to help uncover significant problems and help to develop an appropriate care plan for your patient. So basically, your book is saying the health assessment is important to determine or obtain baseline data and ongoing health status. Patients' status, their health status will change in a blink of an eye. You can go into a patient's room, check their vital signs or obtain their vital signs. Patient is fine, no complaints of pain, heart rate normal, oxygen level is normal. You know, that head-to-toe physical assessment is normal. Well, the next hour, the patient codes. So I'm telling you, patient's health status can change. So health assessment is important to get that baseline data or current data, and then also ongoing. It's ongoing. We reassess all the time. Okay, also, I just said health assessment is important because it helps us to develop an appropriate care plan for the patient. How do we know how to take care of the patient or how to plan our care or develop a care plan for the patient if we don't first do an assessment, a thorough assessment, okay, to include both the history, interview, and the head-to-toe exam? We don't know how to plan an appropriate plan of care or an appropriate care plan. and that's one and the same. So we need to understand why it is important. Also, health assessment helps us to predict health risk. What is this patient at risk of developing? Are they at risk for high blood pressure when we assess their vital signs and their blood pressure is high? Diabetes, heart failure, asthma because their lungs are not normal sounding. So it helps us to predict health risk. Also, health assessment is important because it helps us to identify health promoting activities. Once we assess the patient and we see they're at risk for different health alterations, then we can see or identify different ways to help promote their health. Okay, that's why we can help and teach this patient on patient education, how to be well. So we do that when we assess. We cannot identify health promoting activities unless we assess the patient, because we need to know what health promoting activities are pertinent for that particular patient. We don't know what health risks are involved with the patient unless we do what? A health assessment for that patient. Okay, we can't develop an appropriate care plan if we don't do what? Perform a health assessment to include a thorough interview and a physical head-to-toe exam. Okay, we need to make sure we get the baseline data so we can know what the ongoing health status and what we're monitoring for. Okay, so health assessment begins with rapport building. You have to build a rapport with patients, and I always tell students in the beginning, it's a little scary. You get a little anxious, a little anxiety when you're going into a patient's room and getting ready to perform your physical head-to-toe assessment for the first time. So you need to get to know your patient. Okay, just talk to your patient one-on-one. It's a relationship between the nurse and the patient. So how do you build a relationship? You need to build a rapport. You get to know one another. That is just in any relationship. When you meet someone for the first time, you start having a rapport, or gaining a rapport, building trust. And when you do that, it makes the interviewing process easier. It makes that patient feel comfortable with you to perform the head-to-toe assessment. You're going to be looking at this patient's body. You're going to be inspecting personal areas and invading personal spaces for the patient. So you need to build that rapport. You need to have effective communication skills. Okay, health assessment must be documented. You will attend an EPIC training class. That's a documentation system that hospitals are using. You will have a computer training class at Southeastern Health as well as Cape Fear Valley Hospital. So when you obtain this physical assessment and this health history, you have to document it. So this data must be documented in the computer or the patient's health record, and it must be interpreted. We don't just, as nurses, obtain a health assessment and perform that physical assessment, and then we don't interpret the data. Okay, and we'll go more into that as we go into this PowerPoint. Okay. You have to know different types of assessment, guys. There are different types of assessment, and you need to understand when you do each assessment. You have your initial assessment, which is when we include, we get that baseline assessment. It includes, again, the health history interview and a head-to-toe assessment. When you first go to the doctor's office, think about yourself when you first went to the doctor as a new patient, or you knew someone that went to the doctor as a new patient. The doctor will talk to you the same way with the nurse. The nurse will get some basic information from the patient, and then they will go into proceed to their head-to-toe assessment, getting that baseline data. So you have the initial assessment. Okay. Then also you have a problem-focused or a system-specific assessment. This type of assessment is when the patient presents with a particular problem. Let's say the patient presents to the emergency department with complaints of abdominal pain. That's a specific system. So that's a problem focus. So if you go to the ER with complaints of abdominal pain, guess what? They are going to manage that patient's plan of care surrounding that system, the abdomen. So they will be asking questions in the interview about that system. Are you having any nausea with the abdominal pain? Any vomiting with the abdominal pain? Describe the abdominal pain. Are you having diarrhea with abdominal pain? Constipation with abdominal pain? Sharp pain? Dull pain? They would do focus that care surrounding that specific system. Okay, a problem focused. Um, Also, problem focused can not only be related to the physical health, it can be relevant to social, your cultural, environmental, and emotional factors as well. Okay, if a patient comes in and there are issues going on specifically with anxiety or suicidal ideations, the problem is focused on that particular assessment. Okay. Then you have your emergency assessment. This should be really self-explanatory. This is when you have a patient who is in an emergency situation. Let's say they're not breathing, they have no heart rate. Your patient has now needs CPR. They need emergency care. So you would go in, and that's when you will assess your ABCs. Remember that from your CPR class. Airway, breathing, circulation. It's an emergency assessment. If you go into a patient's room and they're not breathing, they have no heart rate, why are you going to take the time to do an initial assessment when you have to do this whole health history? Hey guys, they're not breathing. They have no heart rate. They're not going to talk to you. That's an emergency assessment. Airway, breathing, circulation, and provide emergent care. Okay? Then you have an ongoing reassessment. I said in the beginning, nurses, we assess and then we provide ongoing monitoring because patients' condition, their status, their health status changes very quickly. Ongoing reassessment. And then you have what you would hear in the hospital when you start doing your clinicals there is an admission assessment. An admission assessment is when you really are doing a complete health history with this patient. It includes biographic data from the patient's name, date of birth, emergency contacts, advanced directives. It's that biographic data, family information, past family history, psychosocial history, any cultural issues that are going on with this patient, nutrition. Again, back with the psychosocial history, this is when we can ask our patients, are there any spiritual or cultural concerns that may be that may affect their health. Okay, nutrition assessment, medications. We have to assess the patient's medications. Allergies. We assess the patient's allergies. Activities of daily living. How does this patient walk? How do they move? How do they dress themselves? Are they able to drive? We want to make sure they're safe with their ADLs. Their past medical history, past surgical history. That's what PMH and PSH stand for. Use of tobacco. Do they drink? Do they use other drugs? So guys, I'm telling you, you have to know the different types of assessment and when is it appropriate to use each type of assessment. And if per se you see on a test, I give you an example of an assessment, you need to, or an example of a scenario, you need to be able to understand, okay, what type of assessment is this? Patient comes in complaining of chest pain. What type of assessment do I need to do? Okay, a problem-focused assessment. Patient has just come back from surgery. The nurse has done an initial assessment. 4 hours later, it's time for this patient to see this patient again and obtain vital signs and assess the surgical site. What type of assessment is this? This is that reassessment. So that's what I mean by understand the types of assessment, and if I give you scenarios, you would know when is it appropriate to use that type of assessment. All right, clinical data collection. Excuse me. We collect data. Nurses collect data. We collect findings, we collect information. So data collection is simply a process of gathering information about the patient's health status. It needs to be in a systematic order. It needs to make sense. It needs to flow. And there are some hospitals that will have already a flow sheet that we have to use in collecting the data. It needs to be continuous. Again, we nurses continuously monitor patients' health data. We assess and we reassess. You're going to hear that all throughout your nursing career as a student and ongoing as a registered nurse. Okay, data can be constant or variable. And there's your definitions of the two. Constant means information that does not change over time. Your race, your date of birth, your blood type. And then, of course, the variable, it changes. And those are your examples. Clinical database. Where do we get this data? Well, we have a clinical database that we obtain data from. We get information, again, from the nursing health history. It's that interviewing process. It's constructive communication. It's intentional, purposeful interviewing that we ask the patient a list of questions to gather a baseline data. It's that interviewing health history. We have the physical head-to-toe assessment. That gives us information about the patient. That's how we get the database, from the physical head to toe and from the interview. We also can gather information about the patient's health status from the primary care provider's history and physical exam. And this will make more sense when you actually do your EPIC training, your computer training, and you will go in and see the doctor's history and physical. It's important to look at that doctor's history and physical, because that is a way that you can gather information about the patient's health status by looking at the doctor's what we call H&P. You will hear us say, did you see the patient's history and physical? Look at the H&P. What is it saying about the patient? What kind of story or information is it giving us about this patient's health status from looking at the provider's H&P? We look at lab tests, we look at diagnostic testing, we look at, again, the past medical history and the past surgical history. All of this data is what we put into a clinical database that tells us the overall story about this patient. Okay? Sources of data. The primary source of data is the patient. Okay? You will find sometimes, this is one of Ms. Gerald's pet peeve. I see students when we're in the clinical setting, they will spend more time at a computer, and I'm sure you have seen doctors and nurses do this too. They spend more time at a computer looking at information about the patient instead of talking to the patient. You can gather a lot of valuable information simply from talking to your patient. The patient is usually the best source, okay? It's the primary source and the best source of data gathering. Get information about your patient. Guess what? Go to your patient, okay? Then you have secondary sources. You may have some patients that are nonverbal. They're not able to express their medical condition or their chief complaint or answer your questions in the interview. Then you can go to secondary sources, family members, other support people, their friends, community workers, neighbors, clergymen, other healthcare professionals, okay? That's key. Other healthcare professionals. What is the physical therapist saying in their notes? Physical therapists, doctors, speech therapists, other healthcare professionals, medical records, reports, labs, testing, relevant literature, other sources other than the patients. But again, these sources have to be validated. Okay, we have to make sure that they are reliable sources. If a family member, we need to make sure that the family member is a great historian, is a reliable historian. But remember, the patient is the primary source and the best source. Okay, usually the best source. And then know some examples of secondary sources. So you have two types of data. We have subjective data and objective data. Guys, this is crucial that you know the difference. When a patient comes, we go into a patient's room at the hospital, or if you're whatever setting, healthcare setting, if you're in a clinic, or if we're doing a telephone visit with the patient, and the patient has complaints of symptoms. They tell you how they feel. That's that patient's perception. That's the patient's verbal account of what is going on with them. That is considered subjective data. It's symptoms. I can't feel a patient's feelings, their attitudes, their values. That is their perception of their own health status or life situation. And I gave you the cartoon there that says subjective data. I have a really sore head. I feel tired. I can't measure that, okay? That's the patient's feelings in their own words. Then you have objective data, which can be seen, it can be felt, it can be smelled. We can use our senses to obtain. It can be measured. This data can be measurable or tested against any standard. Vital signs, that's objective, okay? If a patient says they complains of pain, that's subjective, okay? If a patient has an abnormal blood pressure reading, that's objective. So you're going to really have to understand objective data versus subjective data. Okay? If I give you, again, examples, you need to know, is it subjective or objective data? Okay? Objective data, Susan has a temperature and is crying. I can see her crying. Okay? I can see that abnormal temperature. All right, patient complaints of nausea, patient complaints of anxiety. I can't, that's just the symptoms. That's how the patient is feeling. That's what they said, the patient said, okay? And we know there are many ways that we can collect the data. We observe, we use our senses. We just said there are subjective data, objective data. Objective data, I can use my senses. Okay, we interview the patient. That's the way we can collect data, the interviewing process. Hey, okay, the health history, that is the interviewing process. It needs to be purposeful communication with the patient. And then the physical head-to-toe assessment. We use all three at the same time. While I am doing my head-to-toe assessment, I am actually observing the patient. I am using all of my data collecting skills while I'm talking to this patient. We can do all three at the same time, okay? We need to make sure we're able to organize our data. And you will see this whenever you're doing your computer training classes. We assess the patient, we write down our data. Once we assess the patient, we talk to the patient, we need to go ahead and document that data. Really, we need to document at time that we are obtaining it in the computer, but if we can't document it right away in the computer, then that's when we tell students, have a little notepad, a little small steno pad that can fit into your pocket. I think Miss Britt said this on the first day or the second day of orientation when she went over the clinical guidelines. Have a little steno pad in your pocket. So when you are doing your head-to-toe assessment and you're talking to the patient, you can write down data. But you need to make sure you get the patient's permission and tell the patient what you're doing, because it seems very rude when you are documenting, even in the computer, or you're writing it down on your notepad. Just let the patient know, I'm going to write this information down so I don't forget anything, so I can enter this correctly or accurately in your patient record, okay? As you go through the nursing program, especially when you're getting ready to move into second level, we expect you to gather that information, keep it in your head, and then go and document it. We don't want you to start writing everything down, because you stop looking like registered nursing students and you start looking like waitresses taking orders on a notepad, okay? So just make sure you are aware of that. Again, your data needs to be collected. It needs to be organized. I'm really not going to go all into detail with the testing of the material with the Maslow hierarchy of needs. But just know we document data in a systematic way, and we look at Maslow hierarchy of needs is just an example of how data is documented. Physiological needs, safety, security, self-esteem, and then self-actualization. Okay, it's like a systematic way, or we can use the body systems to collect our data. We just don't go into a patient's room and start at the feet and then go to the head, then to the lungs and the chest. We do it in a systematic way, from head to toe, or Pacific body systems. Okay? And I've already talked about interpreting the data. We write it down, we take notes, we chart as we go along, we ask permission um, as we are interpreting this data. So we know what to recognize as normal versus abnormal. We always need to do something with the abnormal, right? We need to make sure we notify the doctor or the provider of the abnormal, or we need to make sure that we can do independent nursing interventions for the abnormal. For example, if we if a nursing student or nurse go into a patient's room and assess that the patient has cool to touch skin, but then we look at the environmental surroundings in that patient's room and it's freezing cold, independent nursing intervention would be to adjust the temperature in the room or give the patient a blanket and then do what? A reassessment. Okay? So that's nothing we need to notify the doctor. But if we see a significant abnormal finding, abnormal blood pressure, respiratory rate, allergic reaction, pain is not controlled by the current doctor's orders, any abnormal finding that causes a significant health status uh, alteration, health status alteration, we need to make sure we let the doctor know. Okay? Make sure the data that you write down is current. Is current, is reliable, is valid. That's basically in a nutshell what this slide is saying. The information gathered during assessment must be complete, it must be accurate, it must be valid, factual. We need to double check. So if you check a vital sign, and that vital sign is if a patient trends or have normal blood pressure, and then all of a sudden you check the blood pressure and it's significantly high or low, you need to verify that or double check it again. Maybe make sure the patient is in the right position that you check the blood pressure. Um, if you're checking a patient who just came back from having a particular procedure done and they're complaining of pain, and then the pain does not go away, what you need to make sure you double check, did the patient get pain medicine? So that's why we need to make sure we always validating our data, okay? And before we so we don't make sure we do any assumptions, or we don't make sure we interpret the data based on our own biases or something that's not accurate, okay? And just always remember that we view the data in context of the client. The clients, we're all different. Everyone is different. So every patient, we need to look at that patient as a picture of being different. So we provide holistic care, okay? We look at the holistic picture of the patient. And remember, every patient is different. So we need to take into consideration developmental factors. When I assess a baby or a toddler, an adult, an elderly patient, their developmental factors are going to make a difference in what I assess in that patient, okay? Psychological, emotional factors are going to come into play. Family issues are going to come into play. This is a huge one, cultural and diversity factors. When I assess an Asian patient versus a Muslim patient versus an African American patient versus a Hispanic patient versus a Caucasian patient, all of the data that I write down and I collect, I need to take into context, how did that affect this patient cultural and diversity? comes into play. Okay, environmental factors. I use that example about the cold room. I assess the patient and their skin is cool and cold to touch, but the room is freezing. So think about environmental factors. All of these factors we need to take into context when we're doing a patient assessment. Okay, one big one that I know, and you're going to have a whole lecture on culture and diversity. I teach that concept, so I'll go more really in depth with culture diversity. It's really key to understand when we're taking care of patients in terms of assessment, and we obtain a history in a physical head-to-toe assessment, that we take into considerations cultural diversity factors. One right off the top of my head is Hispanic women. When we are doing a head-to-toe assessment on that Hispanic patient, we need to make sure we get permission from the male figure of the household, and that we are basically directing our questions during the interviewing process to the male, because they're the dominant figure and not to the female. That's a cultural and diversity factor that I need to be aware of. Your book really does an excellent job and giving examples of those factors. I'm really not going to go into depth with them on test one, but just know that in general, especially when you're going into the clinical setting, we need to be aware of different factors when we are doing a head-to-toe assessment and an interviewing process with patients. All right, and what is the purpose of that interview? When we talk to that patient, it is intentional communication. We need to first rebuild a rapport. It is so crucial. To me, it's one of the most important steps to assessment. When we assess a patient, the most important step is building rapport with that patient. Okay, it's relationship with that patient. So we just talked about this earlier. It's basically a repeat. Interviewing is the planned communication or conversation with a purpose. It's the purpose intended to get that information from the patient. Okay, to give information, meaning to educate the patient, right? Health promoting activities. Remember the first, or I think the second slide. Health promoting activities. We educate the patient. We identify problems, so we make sure we have the appropriate plan of care. We may have to provide counseling support. We may have to offer referrals or ask the doctor to order referrals for this patient, because we have gained information just from the interview that the patient may have had some anxiety or grieving issues and the patient needs therapy. Okay, that is a part of the plan of care for that patient. In conducting the interview, guys, you need to understand that we have a directive way that we interview and a non-directive way. Okay, non-directive way is where we need to come in and start out is that rapport building. We just let the patient just kind of talk to us, and we see where they are. Are they ready for this process? Are they ready for the assessment to take place? Again, and when I teach culture and diversity, we need to make sure that we understand, am I interrupting this patient's personal space at this time? So it's a non-directive interviewing. Okay, directive interview is when the patient is not so much in control and the nurse has to come in and have to really get this interview done. We need to make sure that the patient understands, okay, you're here in the ER, I need to go ahead and ask you these questions. So there's a place in time when we do a directive interview and a non-directive interview. Okay, during an emergency assessment is not the time to do a non-directive interview. Okay, so just understand the difference between the two, the definition between the two. Types of interviewing questions: closed question, open-ended question, leading question. Okay, typically we do not encourage closed questions. Closed questions, they restrict what information you get. It is generally just a yes no answer. Okay, it is easier for a highly stressed person, basically maybe a patient with some mental illness or some type of psychological diagnosis, then we want to keep it to closed questions. And you'll learn more about that as you go into your mental health course, so class 114, nursing 114. But typically, we do not do closed end questions, okay? Because it's too restrictive. You're going to get just short answers, yes or no. Open-ended questions are used in non-directive interviewing. It really helps the patient to explore and elaborate and clarify their thoughts. It invites for longer answers. It gives the patients freedom to just give us all of this information that they wish. But again, open-ended questions, you really have to be active listening to your patient when you're asking them these open-ended questions, because it's really allowing the patient to have free range and give you a lot of information. Okay, leading questions, that's when the nurse is eliciting, eliciting information from that patient. The patient has less opportunity to decide if that answer is truly right or not. So the patient, the nurse may say, "You're not having pain, are you?" That's a leading question, because the patient may say, "No, I'm not having pain," or "You don't have to, you don't want to take this medication, do you?" That's a leading question. So just know the different types of questions and different examples of close-ended, open-ended, and leading questions. Okay? And this is a good slide of the do's and don'ts of interviewing. Listen attentively. I just said active listening. Using all your senses. When you're talking to a patient, speak slowly, clearly, in the language that they understand. Don't go into a patient's room and do a health history and use this medical terminology. They don't understand that. Don't go in and ask a patient, "Have you urinated today?" They don't know the word urinated. Or, "Have you voided?" They don't know that word. You may just simply have to say, "Did you go and pee-pee? Did you use the bathroom?" You have to use the language that the patient understands, okay? Ask your questions in a systematic, logical sequence, one question at a time, okay? Avoid giving your own personal advice, your own personal viewpoints. Understand your own body language, your tone that you're talking to the patient. Remember eye contact. Use eye contact if appropriate. I put that there because, again, we will learn later on in this semester there are certain cultures that eye contact is discouraged, or prevented. We do not use eye contact, direct eye contact, because it is considered disrespectful in certain cultures, and we'll learn about that. So use eye contact if appropriate. Be calm. Make sure you have time, because some patients take a little longer time to talk to you than others. Okay? But build a rapport. I keep saying that word over and over. It is so important to build a rapport with your patients. Okay? Do's and don'ts of interviewing. Concepts related to assessment, that is on your book on page 2448. There's a table, and it really breaks down the concepts related to assessment, legal issues, oxygenation, perfusion, professional behaviors, thermoregulation, safety, sensory perception, tissue integrity, and mobility. These are all your concepts that you're going to be learning about this semester, okay? Really look at thermoregulation and safety for this testing purposes, but overall, just have a general working knowledge of those concepts as it relates to assessment, okay? You'll always be able to go back to this table as you learn and we teach on those different concepts, okay? All right, here we go. The physical head to toe examination. So the very first, 30, 40 minutes I've been talking about is the history, the health history. Remember, assessment has two parts. That was the health history. Okay, so now we're going to go into the physical head to toe examination. All right, physical exams reveal the normal and the abnormal. You as a nursing student, we're going to talk on and focus on the normal, because if you know the normal, if you start out and understand what is normal or what should be normal, everything else outside of that normal is abnormal. Okay, and we know it's a problem. We need to do, we may not know at this point in your 111 course what to do with the abnormal, but we know it's not normal. Okay, when finding different than anticipated information, or our data is different than what we anticipate, the nurse needs to make a decision about that data. What do I do with it? If you go and listen to a patient's lungs and they are not clear, what do I do? Okay, at this point, again, we just want you to know at this level, the lungs should be clear. Okay, the chest should be symmetrical, evenly rise and fall. Later on, when you get into later into the semester, we will understand and teach you what to do with the abnormals. But for this testing purposes, head to toe assessment, focus on what the normal should be. Okay, complete physical exam starts at the head, and then it systematically works its way down to the toe. Okay, most exams begin with vital signs. You will go into your patient's room, you will start your exam with a full set of vital signs. Okay, and then you go from there with your head to toe assessment. All right, how do we set the stage? We are preparing for this physical exam. We need to go into our patient's room. We need to remember hand hygiene, other precautions. Now we're living in the COVID world. Are we having on our mask, our face coverings? Do we have the appropriate equipment? You do not want to keep going in and out of a patient's room because, oh my gosh, I'm in here to do my head to toe assessment, and guess what? I don't have my pen light. So now you got to go back and come back into the patient's room. Are you prepared for clinical to do a physical head to toe assessment? Do you have the appropriate equipment? Environment, not before you enter. Get the patient's permission. Okay, provide privacy. Make sure the room temperature is comfortable. You're going to be uncovering the patient to look at different body parts. Is the room temperature comfortable? Are there other safety measures in the room? Is the bed at the appropriate height? Okay, is the lighting, we need to make sure we have the right lighting in the room. Okay, make sure the television and the sound is down because you're going to be listening to the patient. Do we make sure we have the right patient? Okay, using two patient identifiers, the patient's name and the full date of birth. Full name, excuse me, I said that backwards. It's supposed to be the full name and date of birth. I just realized that. Full name and date of birth. Get the patient permission. Please, guys, always explain what you're doing to the patient. You get permission, but you explain every step. I'm going to listen to your lungs and your heart. I'm going to listen to your stomach. I'm going to turn you over and just inspect your skin. I'm going to look at your bottom. Again, use language that they understand. And just explain it to them. I'm going to feel or palpate. Well, don't say palpate if the patient, just really say I'm going to feel your pulses. Okay? Explain the steps. Minimize position changes as much as possible for the patient. Okay? Generally, start at the head, do everything in the front, then turn the patient over and do everything at the back. When I say everything, you will see what I mean when we go into this PowerPoint and also when we do the demonstration in lab. Confidentiality, remember HIPAA and confidentiality with this patient. When you obtain this data, you're going to find a lot of information on this patient. It's confidential, guys. And rapport. Let's set the stage, okay, for a head-to-toe assessment. You're getting ready to invade this patient's body space and look at body parts. And if some of you are timid or shy, you're going to have to get out of that now because you are a nursing student getting ready to become a future registered nurse. All right, we always start with inspection. It's just a visual examination. We are looking, when we first go into this patient's room, we are looking at the environment. It's a deliberate, systematic, purposeful inspection. What can I see? What can I smell in that room? What am I hearing in this room? Okay. Do I smell, uh, for an example, if a patient has a Foley catheter and I smell the urine odor, the urine has an odor. That smells like infection. Okay, what am I smelling? What am I hearing? Am I hearing this patient have an audible wheezing or a wet sounding cough? What do I see? Do I see the chest rising and fall? The chest is symmetrical. The size, the shape, the position, the color, the patient's skin. What am I seeing? Okay, again, the environment should be quiet and the light should be sufficient for you to see. Use your, even though it says inspection, don't always just think about visual. We use our senses to inspect. Okay, smell, see, hear. Okay, palpation. This is where we are feeling the patient. Okay, it's touching. But don't, what are we trying to determine when we are palpating? And look at that picture, how the nurse is palpating the patient's skin. We can palpate for texture of the skin. We can palpate for temperature. When we palpate the patient's skin, is it dry? Is it moist? Is it clammy feeling? Is it rough? We can also palpate for vibration, swelling, distension. Is that abdomen distended when we're palpating the abdomen? Is it rigid? Is it crepitus or crepitation? What is that? When we are moving the patient's joints and we can feel the grating or that sensation you kind of feel of those joints popping. We can feel that. That's crepitation. Um, the location, the size, do we feel a mass or lumps? Do we feel any moving organs? Okay. Um, palpation. Are we looking at the amplitude of pulses, which means is the quality of this pulse? Is it weak? Is it fast, strong, bounding pulse? And when I feel a palpate a pulse, is that pulse strong? Or is it so weak I can barely feel it? Tenderness, pain. Two types of palpation. We always do light palpation first and then deep. We typically do not do deep palpation unless you are it takes more training to do a deep palpation. So we typically do light palpation unless you go on to get further training like a nurse practitioner. Okay. Percussion, that's when we tap on the body and it gives off a sound or a vibration. And look at the picture how the nurse is tapping the middle finger against the other middle finger on the other hand, the pads of the finger, okay? It's a rapid, pretty fast striking motion with the wrist, okay? It can indicate if the tissues in the body has fluid or air or if it's a solid mass. And on in your book, when you get your book on page 20, let me see, where is it? 2442, page 2442, it talks about the different sounds of percussion and what they mean. Okay, flatness. Dense tissue is extremely a dull sound. It's a very dense tissue when you hear a flatness sound. It typically will be heard over muscle or bone. Dullness is a dense tissue, and that's typically heard over the liver or spleen. But the normal sound that we should hear when we percuss is resonance. Okay, the hollow fill sound with air that we hear, that we would tap, excuse me, with the lungs. That's resonance or on the vowel sounds. Hyperresonance is not normal in a healthy body. Please know that. That's why I underlined it. If you hear hyperresonance, that hyper hollow sound, that is not normal. That means you're having, it's a booming sound, and you may have especially of your lungs. You may have some emphysema, a lot of heavy fluid that's building up in the lung. Hyperresonance is not normal. Okay, tympany is a drum-like sound. It's the most dense tissue, and that's typically heard over the stomach, and it's air filling, or if a patient has a lot of gas buildup. But it's a good chart in your book, and it talks about the different sounds for percussion. And this is the order. We always do our head to toe assessment. We start with inspection, palpation, percussion, and auscultation, with one exception, and we'll get there. Auscultation, this is when we're listening. We can listen without our stethoscope, which is direct listening. We can actually hear if a patient is wheezing. We can hear that wet sound. We can hear peristalsis moving in the bowels. Okay, we can hear the grating of the joints also. And then we have the use of our stethoscope, that we can hear heart sounds, lung sounds. The stethoscope has two size, the diaphragm and the bell. The diaphragm is used for high-pitched sounds. With normal heart sounds, lung sounds, normal bowel sounds, we use the diaphragm. We use our bell of the stethoscope with low-pitched sounds, okay, like our heart murmurs, or some bowel sounds that are hypoactive, or we call sluggish. Can't hardly hear those bowel sounds, okay? Diaphragm and bell. These are just some common equipment that you may use for an assessment: your stethoscope, your pen light, gloves. Some of them you will use, some you may not use, like a vaginal speculum. We're not going to use that. We're not at nurse practitioner school, but your tongue blaze, your otoscope, blood pressure cuff, pen light. This is just some common pulse oximeter, common equipment that we will use during our head-to-toe assessment. Oh my goodness, when was the last time anyone checked on Mr. Klink in room 207? Wow, we don't want our patient to end up looking like this. Again, assessment is ongoing. Okay, we do our initial assessment, and we always reassess the patient. Patient's health status will change. So when you go into the clinical setting and you assess your patient, and you come out of your room and you say, hey, Miss Gerald, I've already assessed my patient in room 207, and then you don't go back in the room and reassess your patient, is that being a good, safe nurse? Is that safe quality practice? It's not, because we need to continuously monitor our patient, reassess our patient. And again, you probably ask, how often do we reassess our patient? Some facilities have certain time frames where if you work in the ICU, it's typically every hour, every 2 hours. If you work on a general medical surgical unit, it's typically every 4 hours unless there's a certain procedure done. So it will vary. And how would you know that? Based on your initial assessment. Then you would know when to reassess your patient. But it looks like no one has checked Mr. Klink in room 207, because he has turned into a skeleton. Don't let this be your patient. Okay, we always say we start with vital signs, your heart rate, blood pressure, oxygen saturation, temperature, respiration, and always know your your normal vital signs. That's in your book on page 2437. Table 34.3, know normal vital signs for your adult and your older adult. Okay? All right. Not really going to test you a lot with the pediatric patient, but with the adult, you need to know normal vital signs. All right. Not for 111. You will go into your pediatric world in the summer when you take nursing 113, but for 111 now, just the adult and the older adult really know the normal vital signs. And know that pain is a vital sign. Okay, you're going to have several questions on this test related to pain. Pain assessment is one of the assessments that not only as nursing students, but unfortunately some nurses still do not see the significance of a accurate pain assessment. Pain is the sixth vital sign. You need to know the pain assessment, the PQRST. You have to know it. Precipitating factors, what provokes this pain? What helps the pain get better? What makes it worse? The quality of the pain, how is it described? Does the patient describe his pain as sharp, throbbing, achy, dull? Okay. Where is the pain located? The region. Does it move? Does it radiate? The severity. Now, we're nursing students, and nurses are good at this one. They'll say, "Are you having pain, Mr. Jones? Can you rate your pain on a scale of 0 to 10? And that's all they got. That's all they say. And then I'll ask the student, where is the pain? Does it move? Does it radiate? Describe the pain. What helps the pain? What makes the pain worse? So you have to go more in detail on the pain assessment. Time, T, onset, duration. When does the pain start? How long does it last? Does it reoccur? Do you have a history of this pain? Okay, you have to, what associated symptoms are with this pain? Remember, again, another cue, culture reviews. People from different cultures view pain differently. Okay, African Americans, we're not going to be so quick to say we're having pain. Hispanic culture, not going to be so quick to say they're having pain. Asian culture is not going to be so quick to say they're going to say they're having pain. You're going to have to look at other symptoms. Look at your patient, inspect their facial expression. Okay, inspect how they are holding themselves, if they're having stomach pain or chest pain, are they groping their chest or grabbing onto their stomach? Are they sweaty, diaphoretic, high blood pressure that's out of their normal range? So really understand pain assessment. You will see several questions on pain assessment, I'm telling you, because that's one of the things that we need to really improve on, okay, in healthcare. And this is just another example of what you may see. If a patient is nonverbal, they would do the Wand-Baker face pain scale, where we have the patient or the child, the nonverbal patient or the child, to look at those pictures to describe their pain. They can't tell you a number, but they can kind of point to the picture, or you can look at their facial expression and see what it mimics based on those pictures. Okay? So you can't always say, well, the patient is nonverbal, I don't know how to assess pain. Guess what? They are already developed pain rating scales. General guidelines. We're getting ready to go, guys, into the systems now. Each body system observes for mobility, range of motion, and coordination. With each body area, you need to note the color of the body area, the skin color. If each body area has any rashes, any lesions, you need to inspect the hair, the nails, palpate for general texture, turgor, temperature, assess for any wounds, size, drainage, any dressings, casts, Foley's, any type of drains. When you first go into this patient's room, just a general overview. This is what you're looking for, okay? And when I say wounds, drains, it could be a wound vac, it could be a Foley catheter, it could be a rectal tube. Some patients have diarrhea so bad that they have to have a rectal tube inserted in the rectum. So you have a urinary Foley catheter drainage tube, and you can have a rectal drainage tube. Does this patient have an IV in sight? How many IVs? Just a general overview, general observation of the systems. Neurological, you need to do a neuro assessment, okay? First thing you ask the patient, can you tell me your full name and date of birth? Do you know where you are? Tell me where you are. What time is it today? Can you tell me what year this is? Tell me what hospital you are. Talk to me. Why did you come to the hospital? See if they know what situation, if they're oriented to person, place, time, and situation. Are they alert? Or are they able, if they're in the bed with their eyes closed, do they open their eyes when you call their name, or do you have to give them some type of tactile stimuli? Tactile means you touch them. You have to touch their shoulder or touch their arm to arouse them. Okay. Um, how they're psychosocial. Are they happy, cheerful, cooperative, calm, or just a flat affect? They seem aggressive. How is their overall appearance? Okay, just a neurological. Are they able to communicate with you? Clear speech. Hair, skin, and nails. Not going to go through those. You will see those in the demonstration, but that's what you are assessing for the skin, hair, and nails. Okay. The color, again, the temperature, to palpate the skin, is that temperature cool to touch? Is it wet? Any swelling or edema noted to the skin? Okay. Nails, is the nail bed um, clear and smooth? Or is the nail bed, is it torn? You see some people have their nail beds a really rough feel and it's not smooth. Do they have clubbing, which is rounding of the nails? That can indicate a respiratory disorder. When we look at the nail bed for clubbing, should not have any clubbing. Braden risk assessment skill, really important, because the Braden risk assessment skill will assess the patient for risk of developing bed sores or pressure ulcers. Again, I said we have to assess the patient to identify risk. Well, the Braden risk assessment skill is used to identify the patient's risk of developing bed sores or pressure ulcers. So we look at this sensory perception. Is it a number 1 through a number 4? No impairment, you score the patient a 4. Completely limited, a 1, and in between. And you go right down the list. Moisture, meaning are they incontinent? Are they diaphoretic? Do they um, have diarrhea and they're incontinent of bowel? Are they sweaty? So moisture. Activity, are they bedfast or do they walk? Or do they have to be, are they able to sit up in a chair? Are they mobile? Any limitations or completely bedbound? Nutrition, adequate, very poor, or excellent? Friction and shear, is there a problem? Meaning when they're able to move up and down in the bed, do they already have a stage 1 bed sore? So Braden risk assessment is used to assess the patient's risk for bed sores or bed or not bed, bed sores and pressure ulcers. Sorry, guys. Again, your head for size, shape, symmetry. Perla, we look at the eyes. We use our pen light here is when we're checking the pupils are equal, round, and reactive to light and accommodation. That's what Perla means. And on our pen light, when we shine the pen light on the patient's pupil, what size is the pupil? And that's when we can look at the size of the patient's pupil and we can verify it against these circles on our pen light, okay? And that's how we know and to document the size, the finding of the patient's pupils. Are they accommodate to light? Are they round, reactive? That's what Perla means, okay? And we'll talk about other visual examinations on the demo, also in Skills Lab. Ears, nose, and mouth. It's right here for you. We will go more in detail. Well, again, during the skills lab on the demo, we will go more into the hearing test, how we check the patient's hearing test when we look at the nose, look at the mouth, okay? Neck and breast. What are we looking for when we're checking the patient's neck? Is that trachea in line? Is it deviated? Does the cervical have no lymph nodes that can be palpated? Okay. The breast size, are they even in size? Do we have any masses? Are there any discharge coming from the nipple? The characteristic, men and women. Okay. And this is another breakdown of the head, ears, eyes, nose, mouth, and neck assessment. what you should see and what you will be doing on your head to toe assessment. Okay, at the end of this semester, you will actually demonstrate a full head to toe assessment on one of the mannequins, and you will be checked off that you are able to competently demonstrate correctly a head to toe assessment. And these are all of the things that you're going to be assessing, and you will have plenty of time in lab to practice, and you will watch the videos of the demonstration, and then we will discuss it to make sure that you understand according to the checklist. Okay? Your chest, we inspect the chest. Is it a round shape? Is it symmetrical, meaning even on both sides? Is it a barrel chest, which means is it round? Your chest should not be rounded. That can indicate a patient has COPD, but you don't have to know that at this level. Just know the chest should be symmetrical. It should not be a rounded shape. You should not have a kyphosis where you have the hump back, or the scoliosis where your back is in your back and chest is in an S shape. Okay. Are there any scarring that you notice in the chest? Is the chest rising and falling equally? That's what you just can see, right? Again, we inspect the lungs and we go into our abnormal patterns of the lung. Is the breathing or the respirations fast? Are they slow? Are they deep? Know your respiration rate, okay? How does those respirations sound? Are they wet sounding, or what we call the death rattle in a patient, okay? So torus, or the death rattle in one of a comatose patient. These are different respiratory patterns. I would please encourage you just to Google these different breathing patterns or respiratory patterns so you can hear what they sound like. Kussmaul, Cheyne-Stokes, tachypnea. Okay, just Google these respiratory patterns so you can hear what they sound like. These are all abnormal, by the way. We don't want these. These are abnormal. We want even respiratory patterns, okay, within what 12 to 20 range for respiratory rate. This is a slide that talks about how to assess lungs, and we will go more into this in the demonstration. In that pattern, that is the way you assess your lungs, from the anterior, which is the front, the lateral, the side, and the back, the posterior. That's how you assess your lung sounds, okay? That's the pattern. Again, lung sounds, crackles, rhonchi, wheeze. Google these sounds and you can hear what they sound like. These are all abnormal. Your lungs, a patient's lungs, should not sound like crackles. They should not have that high-pitched sound. Crackles are not cleared by a cough, and it's a continuous sounds like almost like snap, crackle, and pop. It's a crackling sound. Okay, it's not cleared by a cough. Rhonchi is that coarse sound, and it's almost like a patient is snoring. Rhonchi is cleared by a cough or if a patient needs suctioning. Google and listen how rhonchi sounds. Wheeze is a musical sound. You can hear it both during inhaling, which is inspiration, and expiration, usually louder on expiration, continuously. Okay? Rhonchi is heard during inspiration or expiration. All right. Crackle is generally heard during inspiration. But again, Google those sounds so you can hear. These are abnormal. Lung sounds should be clear. Should not have wheezing. Should not have rhonchi. Wheezing, and for testing purposes at this level, again, guys, you do not have to know what causes wheezing. You don't have to know that asthma or CHF or emphysema causes wheezing. You just need to know that wheezing is a high-pitched musical sound and it's abnormal. Okay. Again, with rhonchi, you do not have to know what typically causes a patient to have bronchi, but just know that if a patient does have bronchi, that snoring sound, and it generally will disappear if you have the patient to cough. That's important to know. If a patient coughs, that bronchi would generally disappear, okay? And then the lungs will sound clear again. Crackles, coarse crackles, fine crackles, really not at this point going to distinguish the two, but just Google these sounds so you can hear what they sound like. Crackles or rails is like a Rice Krispie cereal. What is it? Snap, crackle, pop. It's a popping sound. But it's typically not cleared with coughing. Okay, sounds like and coarse crackle sounds like a strong bubbling or gurgling sounds. Okay, but just know typically crackles. Not going to really need to know the difference between fine and coarse crackles. Just know crackles is abnormal. All right, just this slide is just FYI. Diminished breath sounds, not normal. Absent breath sounds, not normal. Your breath sounds should be clear. Patient's breath sounds clear. Okay? All right, let's go to the heart. You will have to know the different locations of the heart sounds. The aortic, pulmonic, Erb's point, tricuspid, and the mitral valve. You have to know, you have to hear the normal S1 and S2, lub-dub, lub-dub. So when you listen to the patient's heart sounds, you're going to listen at all 5 areas of the heart. This is a great picture that shows you where to listen. The aortic, okay, the pulmonic, the Erb's point, the tricuspid, and the mitral valve, okay? You should hear the lub-dub. 5 areas for listening to the heart. It tells you exactly where to go. The aortic is the second intercostal space. The pulmonic is the left intercostal space. The Erb's point, okay, that's the third intercostal space. That's where you're going to hear the S1 and S2. The tricuspid is the lower part of the sternum. It's on the left side. And then the mitral valve is on the fifth intercostal space, again, on the left side. Okay? Those 5 areas, you will listen to those when you're doing the head-to-toe assessment, listening to heart sounds. And there it is. It's just a quick, I saw this little cartoon, tricuspid and mitral valve closing. That's what the S1 is really going on for those of you who want to remember what you learned in anatomy and physiology. Not really going to go into detail here, but we will talk about this more when we go into perfusion. I teach perfusion as well. So not going to need to know it right now, but just know your heart sounds. We're listening for the S1 and S2. Okay? Heart and vessels. We have central vessels. We auscultate the bruit on the carotid arteries. We have to listen for the bruit, and we also have to feel or palpate for the pulsation, or what we call feel the thrill. We listen for the bruit and we feel the thrill. Auscultate the bruit and palpate the pulse for the carotid artery. We never ever palpate the carotid arteries in the neck at the same time. Why? You can cause occlusion of the blood flow and the patient can pass out. We palpate the carotid artery one side at a time. We also note if there's any jugular vein distension, JVD. This is our central vessels of the heart. The peripheral vessels, we will look at the blood pressure. We will look at the pulses. Okay? These are also the 5 P's for a circulation assessment. So we see if the patient is able to feel pain, if they have pulses, if they have pallor or they're white, don't have any color at all, if they're able to feel, and if they can move, paralysis. Okay? This is a good cartoon to help you to remember the circulation assessment. Can they feel? That means their perfusion. Okay? Do they have pulses? Pallor, should not be any pallor. Paresthesia, they should be able to feel, excuse me. So they should say no to this. Pain, they should say ouch. They can feel it. That means they have perfusion. They have circulation. Paralysis, no. They should say no. Patient should say no. They can move. All right. Again, we are focusing on the normal. And this is a picture that shows you your peripheral pulses. You need to be able to palpate the carotid artery one side at a time in the neck, the brachial artery, which is in the bend of your elbow here, the radial, your femoral, your popliteal pulse, your posterior tibial pulse, the popliteal, excuse me, is behind the knee, the femoral is in the groin, the posterior tibial is in the index of the ankle, and then on top of your foot, the dorsalis pedis. Okay? All should be normal, should be palpable. You should be able to feel it, and they should be strong, not weak, not faint, not bounding, but they should be palpable. Okay? Not really going to go through this as much as what I want to point out is that when you are doing an apical pulse, I think I have that in bold on this slide. You always listen to an apical pulse for 1 minute. So when you're doing your checkoff, you will say, I am listening for the apical pulse for 1 minute. You don't have to physically do it, but you need to say it. Okay? We need to look at the back for symmetry, the chest for symmetry. We already talked about the heart sounds, but I need to make sure you know we do the apical pulse for 1 minute. And we need to help our patients. Guys, listen to me closely when I say this. If we have patients that are not able to move, or they're elderly and they can't move as well, or even if they're paralyzed, some of you are going to be going to the spinal cord and the brain injury unit. These patients are paralyzed, the majority of them from the head, the neck down. Some of them are paraplegic from the waist down, or some of them are paralyzed from the neck down, okay, quadriplegic. So you have to assist these patients. They can't turn and move, okay, when you're doing the assessment from the back and you're turning there from side to side. Please, please remember that. You may see it again. Remember that. All right, this is where I was telling you we have an order that we go in: inspection, palpation, percussion, and auscultation, with the exception of the abdomen. The abdomen, we're going to listen for the bowel sounds. We're going to palpate for tenderness or masses. Where the abdomen is divided into 4 quadrants: right upper quad, right lower quad, left lower quad, and left upper quad. We have to listen for bowel sounds. Bowel sounds should be normal. They should not be active, hyperactive, or hypoactive, and of course they shouldn't be absent. But in order to determine if the bowel sounds are absent, you have to listen for a full 5 minutes. You can't just put your stethoscope to a patient's abdomen for a minute and say, I don't hear anything, there's no bowel sounds. No, no, no. Crucial. I have it underlined. 5 minutes to determine if the bowel sounds are absent. That is not normal. Want to make sure a patient doesn't have any obstruction. Okay? You should hear active bowel sounds. When you put that stethoscope there, within a couple of 30 seconds, you're going to hear some rumbling. But with the abdomen, we always make sure we inspect, then we listen, then we palpate, and then we percuss. Know that order for the abdomen. Why do we change up the order? Because we want to make sure that if there is any fluid going on in the abdomen, that we are not pushing that fluid around or moving anything. But so we want to listen first and make sure the bowel sounds are not distorted. The abdomen, a normal abdomen should be soft, non-tender, and non-distended with active bowel sounds. A normal abdomen should be soft, non-tender, with normal bowel sounds, okay, non-distended. And that's just a picture that shows you what organs are where, and you can remember that from your anatomy and physiology. Again, abdomen assessment. The only thing I really want to point out here, we can use the diaphragm to make sure we are listening for our bowel sounds, with the exception of the aorta. We always want to listen to the aorta for bruits, and we need to use the bell of the stethoscope. Okay, and that is like mid-abdomen, almost at the lower part of the esophagus and the top of the abdomen, and that's our aorta, where we can listen for that. Listen for the bruit, and we use the bell of our stethoscope. Really, please remember that, okay? We need to inspect the female and male genitalia, ask them how they're urinating, are they having regular bowel movements, have they noticed any unusual discharges, any odor. All of that is abnormal, okay? They should be urinating without difficulty. They should be having regular bowel movements without constipation, without loose stools, without gassy, bloating feelings. They should not have odor or discharges, all right? You can typically ask this if they're able to let you know, unless you're doing a problem-focused assessment. If a patient comes in with this complaint, then of course you need to go more in detail. But otherwise, you can just ask these questions. Urinating status. Make sure that we palpate the bladder for distension. If they have a Foley catheter, you're going to observe that catheter for patency. Make sure their urine color in the Foley catheter is a yellow color or a straw color. There's no blood in the urine. We need to monitor the intake and output as ordered, as per the physician's order. Make sure you understand the patient's voiding pattern. Are they incontinent? Musculoskeletal, we look at bones, muscles, and joints. Can this patient walk? Can they move? Are they stiff? Do they have equal strength? If you ask the patient to squeeze your hand, is it equal on both sides? Are they contracted? Do they have involuntary movements and tremors? Can they tolerate can they tolerate passive range of motion? Are they able to do active range of motion, which that means they can move their own self? Or do we have to do passive range of motion, which means we are moving the joints, okay? We are moving the extremities, and their patient is not having pain. All the while we're noting the patient is having pain or not. A detailed upper and lower extremity assessment. Really look at these. We'll go more into detail on the demo in the lab. Note here the Babinski reflex should disappear by age 2, so a patient should not have a Babinski reflex. Again, we're talking about the adult patient, so there should not be a Babinski reflex. And that's where you take your the little hammer or even the pad of your finger, and you go across the pad of the foot, and the patient should not have a Babinski reflex. Okay, if they do, it's abnormal. And I'm not going to read all these for you. They are right here for you and on your skills checklist. All right, safety and documentation. At the end of the head to toe assessment, we need to make sure that we leave that patient in a safe position, right? That bed is in the lowest position. The bed is locked. The side rails are up as ordered, because some facilities say if all side rails are up, that is a restraint. So that's why I put side rails up as ordered. We need to make sure that we, as nurses, provide hand hygiene as appropriate and other precaution. Okay, observe the overall safety of that environment. Does that patient have the call light in reach? Is the bedside table and all the other personal possessions within that patient's reach? And then we do what? We go and document. Okay, we document, which means we record the data, the findings. And then we report any abnormal findings. We interpret that data, we validate it, make sure we've checked it, double checked it, and we report any abnormal findings. Holistic care across the lifespan. I'll go more into this in class. This is where we remember I said every patient is different. So when we're doing our head to toe assessment, we have to keep in mind the patient's psychological state, their cognitive level, their emotional level. With different factors. So look at that patient across the lifespan. Holistic care is holistic health is a clinical mindset that considers more than just the physical, but it looks at cultural, it looks at spiritual, emotional factors. Okay, guys, these next 4 slides, you have to know when we assess a patient, how do we assess a newborn and how do we assess a toddler? Just in general, not really looking at the head to toe piece of assessing an infant or a toddler, not in this course, you'll get that later, but just in general guidelines. You have to know these, and I have put it plain as day under each lifespan, newborns and infants. The parents typically hold that newborn when we're assessing that patient, okay? Toddlers, the parents, again, that toddler will sit on the parent's lap. We let the toddler explore our instruments before we go in and start assessing the patient, that toddler. We explain, or not explain, we allow them to play with our equipment, because by doing that, that gets them less scared of the procedures. Okay, we never ever tell a toddler or a child that the assessment, any part of the assessment, is not going to hurt, because guess what, that offers false hope, and if we do something on the assessment that hurts the child, then we've lost their trust. Okay, so we don't do that with the children, and we make sure we go ahead and listen to them before as the first part of the assessment, and not at the end, because we don't want to start palpating and percussion and then we listen at the end and we've caused them to start crying. Okay, preschoolers, school age children, I'm not going to read these for you. If you have any questions, we'll go over these health assessment across the lifestyle in class. Adolescent versus the young middle adults, and then your older adults. Okay, special attention that we need to really look at is their mobility and how we need to help them and moving them from side to side. Okay, and when we're doing that physical assessment, can they hear us when we're talking to them? Can they see? Providing a lot more rest periods when we're doing an assessment on the older adult. Okay. And then the next slides are all of our NCLEX practice questions. I think I put 5 of them up here. Be able to answer these questions and discuss these questions in class, okay, during lecture. I'm not going to give you the answer. You should be able to find all of these answers from the PowerPoint and just from listening to my PowerPoint, okay? Some of them you may have to have your book. So again, we will go through these in class. Another NCLEX practice question. NCLEX practice question. NCLEX practice question. And NCLEX practice question. Okay? All right, wrap up. Make sure you are able to discuss, again, the general assessment checklist. You have a checklist for a head-to-toe assessment on the adult. You have to be able to demonstrate a full head-to-toe assessment on the mannequin at the end of this semester. Okay? You will have plenty of time to practice in lab. You will have plenty of time to practice in clinical. Don't let your patient know you're practicing on them, but that's essentially what you're doing. But you will be able to look at the videos, practice in lab, practice at home. Ask your sister, your husband, your wife, your friend, your brother, a neighbor, to practice a head to toe assessment on them. Okay, the more you practice according to the skills checklist, the more fluent you will be. Okay, be able to discuss those practice in class questions from this PowerPoint in class, and then here is a video. It's a YouTube video about 45 minutes on a head to toe assessment. Now, in this video, it really does go a little more in detail, but it really gives you a great idea from head to toe how to complete a head to toe assessment. You will have your skills check off that you go by. You can watch this video, okay? So, and practice at home. All right. If you have any questions, we will go again and we will discuss those questions in class. But I do expect you to listen to this PowerPoint. I know it's lengthy. Do not listen at one setting. Listen for about 20-30 minutes. Stop it, take notes, start back, listen some more for another 30 minutes, stop, take notes, and then finish it and take your notes. Be prepared. Come to class with any questions or anything I need to clarify, okay? Don't hesitate to email me. And guys, I look forward to this exciting journey with you in your nursing career. All right, thank you.